Hello and welcome everyone to the Menopause Symposium, where we bring you new and exciting insights from the world of menopause. My name is Vasomotor. I'm a gynecologist and a menopause specialist in London. And I'm joined today by my friend and colleague, Vikram Talaulikar, who is also a fantastic menopause specialist from University College London. We are delighted to be starting these symposium, and we hope to be bringing new and interesting articles to you every month. For now and in the future, we're hoping to do it streamed directly online. So today we brought you a very interesting new RCT. Vikram, can you talk us through what we're talking about today?
So thank you, Basil, for the introduction. So today we are going to discuss a paper that is quite topical. That's because recently Fezolinetant, one of the NK3 receptor antagonists, has been granted a UK license by MHRA, and that's for treatment of moderate to severe vasomotor symptoms of menopause. So the study we are going to quickly review and then discuss is efficacy and safety of Fezolinetant for moderate to severe vasomotor symptoms associated with menopause. And this was a phase 3 randomized controlled trial with the first author being Johnson K.A.
Indeed, and it's one of a series of RCTs called Skylight, and they've been all sort of focusing on the clinical applications of Fezolinetant. So maybe you can tell us a bit more about what is the role of this new agent in NK3 antagonist?
So Fezolinetant has gained a lot of attention, interest, because, as I said, it's one of the NK3 receptor antagonists. We know that menopausal hot flushes originate in the hypothalamus because there is the heat center, the thermoregulatory center in the brain hypothalamus that's innervated by certain neurons, the K and the Y, and they are stimulated by the neuropeptide neurokinin B. They act at the neurokinin 3 receptors. And so if you can block the receptors, it should be effective in reducing these hot flushes. And that's exactly what the Fezolinetant is supposed to do. And of course, we know that hot flushes affect almost 70–80% of women. And in about 1/3, they are quite severe, debilitating. For others, they can also disrupt quality of life. So any medication that can block the severity or the frequency of these flushes is welcome. Fezolinetant is non-hormonal. So of course, one advantage is women who can't take hormones or wish not to take hormones for personal choice. If this medication works and we look through the paper, then of course it will be an attractive option for those women. How it does in real life, we'll have a discussion once you go through exactly what the study was looking at.
Indeed. So this study was actually quite a hard effort in that it was multinational. It happened across 7 countries, and it recruited over 140 sites in United States, Canada, Czech Republic, Latvia, Poland, Spain, and UK between 2019 and 2021. So it's actually quite a hard effort, specifically in the peak of COVID, to pull this off. And it has quite a interesting design in that they were randomizing women who met the eligibility criteria. These are primarily women between the age of 40 and 60 to 65. I'll go through the inclusion criteria in a bit more details, but they were randomized into one of 3 groups: either placebo, Fezolinetant on 30 milligrams, or Fezolinetant on 45 milligrams. So that happened for 12 weeks, where they collected the co-primary outcomes. And then after that, they re-randomized those in the placebo group for an extended period of 40 weeks to one of the 2 agents. So quite an interesting trial design. Now, off the bat, the key element that we have to sort of discuss in details is that majority of the co-investigators are actually employees of the funder, Asteya, who is the producer of Fezolinetant. So it's a completely pharma-funded RCT, and we will explore that in a little bit in-depth manner later on. So going through the inclusion criteria, as we discussed, there were women between the ages of 40 and 65, BMI 18 to 38. they had menopause either with spontaneous amenorrhea for more than 12 months or more than 6 months with an FSH above 40, or they had a bilateral oophorectomy 6 weeks ago. They also needed to have suffer from moderate to severe VMS and also are willing to undergo a transvaginal scan and endometrial biopsy at week 52, which is towards the end of the trial. No, it's an interesting fact because they did not say week 12, which is the end of the comparison to placebo. So something to bear in mind. Now, the inclusion criteria is nothing out of the ordinary. They excluded those who are on active medication that can affect cytochrome P45. They also excluded those who had cancer, except basal cell carcinoma, those with hypertension, with active bleeding, or any other chronic disease, specifically liver and kidney. What do you think of this exclusion criteria? Do you think it's representative of the wider population we would probably be adopting this treatment on?
Yes, Basil. I mean, generally, it does cover the age group between 40 to 65. So that would cover almost more than 90% of women who are going through the menopause or perimenopause, early menopause. Of course, it covers a wide range of BMI, and it's mainly aimed at postmenopausal women, either more than 12 months of amenorrhea and significant vasomotor symptoms. Of course, it's a 52-week study, and I think we'll discuss the shortcomings at the end, that it's a limited data in terms of the longevity of the trial. But overall, although people have criticized that we don't know it's in women above 65, whether it will be effective, and then you should have at least this much of vasomotor symptom, I think overall it did encompass or looked at the right target population, from my opinion.
I mean, to me, I think a missed opportunity is excluding those with previous history of cancer, because I think these are the primary benefiters of such drug, because they are excluded from taking HRT, perhaps a follow-up RCT to be conducted.
Yeah.
So moving to the outcomes, they looked into so it's a co-primary outcome design. The analysis is quite interesting as well. We'll unpick it step by step, but they looked into both the severity and the frequency of vasomotor symptoms or hot flushes. And to pick on these, they used a 24-hour sort of electronic diary. There isn't much details in the protocols or any of the Skylight RCTs that I could find on how they actually use this diary. They reference the FDA sort of recommendation on measuring these, but it's not very transparent, I'm afraid. So it's a bit like a black box, and we can't really see inside. They also focused on sleep outcomes, and they used several validated scales to assess the impact of the treatment on sleep parameters and also on overall quality of life using the MinQL score. So I think these are fairly valid outcomes to measure. However, I think we probably would have loved to see more menopausal outcomes captured in addition to these, to offer a little bit better insight into the overall impact of the medication. The statistical analysis is quite advanced, I must say, and I was very impressed. So first of all, they used least square means, which many of you audience might not be familiar with, which is basically, instead of just summing up the measures of the frequency, it's a way to sort of adjust for the randomness of the data, and if any data is missed at random. So it does offer a little bit more valid results for longitudinal data with like some valid assumptions. And they also used what is called a mixed model repeated measure. And this is quite a nice model in that it adjusts for the dose treatment effect, as well as adjusting for baseline factors and confounders. So it's not a simple linear regression analysis, which is commonly what you would see in these trials. It's a more advanced model that is adjusting for the linearity on the correlations between all the four core primary efficacy endpoints. So it does, in my opinion, add a bit more validity to the results. They used in their analysis every participant who received at least one dose of the drug, consistent with an intention to treat analysis, which is again what we would expect. And also they looked into type 1 error in all of the four co-primary outcomes, so not just in one, which again is adding another layer of sort of validity to the type of analysis they did. They did look also for if the data was missing at random or not. Obviously, with such big trial across so many different countries and settings, losing data is very easy. So it's quite a reassuring step what they've done. Now, moving to the results, they had 501 women randomized. And the key interesting thing is that in the 12 weeks period where they were compared to placebo, the adverse events were actually not very significant. And I think the most common was headache. I think this is reassuring, isn't it, in your opinion, compared to other non-hormonal treatments for menopause? It's
Yes.
probably quite a valid concern for most patients.
Yes, I agree, Basil. So that was quite reassuring. Nothing much there.
Yeah. And then moving into the results. Now, interestingly, the 30 milligram dose did reduce VMS frequency and also severity more than placebo, as well as that of the 45 milligram dose. Now, the interesting finding is that there was a placebo effect. And so even with just placebo, there was a reduction in the severity and frequency of VMSs. And the improvement in sleep and overall quality of life was more pronounced with the 45 milligram dose. So that also bears in mind in terms of what dose we will be most likely using in clinical practice, both on the short and long-term benefits. And then,
Basil, if I say that, it's reassuring because most menopause clinical trials do show a placebo effect, isn't it? They do show that there's a significant placebo effect, especially in the beginning with any intervention related to menopause. So it was good to see that there was that 35% drop just with placebo. And then there was the further another 25% drop with the fezolinetant. So overall fits in with previous research.
100%. And I think if we look at figure 3, it completely aligns with what you're mentioning, Vikram, because as we can see, the effect started within 1 week of getting either doses as well as the placebo. And then it was maintained all the way to week 12. And then after that, it sort of plateaus. So there is no regression or like recurrence of VMS symptoms after maintaining the dose. And it was sort of stable with either doses as well. So that is very reassuring in terms of the stability of the dose treatment effect. And on the flip side, in figure 4, what we can see is basically that there was a significant improvement in sleep only with the 45 dose. It was not that significant with the 30 milligram dose, and it's not maintained on the long term. So that probably puts into perspective what I was mentioning is that we don't have other data on other important menopause outcomes to help us really counsel patients in terms of if you are starting this treatment, what is the primary symptom you'll be addressing and what are probably other benefits you might reap, but they will be less visible and less prominent compared to the effect on vasomotor symptoms. What do you think?
Yes. I mean, a little bit of effect on sleep with the highest dose, 45 milligram, but we don't know how long it will last, how significant it will be in real clinical practice. Also, there's no evaluation of mood or say energy or libido, all those sort of other parameters that you've been talking about. So realistically, at the moment, you could only say, yes, you'll have 50% reduction in vasomotor symptom, but you really can't comment on the other aspects.
100%. So we've sort of touched upon some of the limitations. I think one that really sort of disappointing to me is that they didn't really elaborate on how they measured the outcomes. Also, when you're dealing with such big trial across so many countries, you'd love to know more information about how were the outcomes collected, where they were, harvest, and how were there any quality assurance for the data, how more information about the data handling. I think all that feeds into more validity of the trial. I could not access the protocol. I think the trial is prospectively registered, but there was no. Usually, a good feature is to get a full protocol and a full statistical analysis plan prospectively before the trial is done. I think that also increased confidence, specifically from a pharma-funded trial, which is again unfortunate in this case. We touched upon the fact that it is pharma funded and the fact that they did not mention other menopausal symptoms. I don't know. What do you think about pharma funded trials, Vikram? Where do you stand on it in your clinical practice?
To be honest, Basil, I probably am not the best person to comment because I don't understand fully how these trials at such a high level are sort of managed and handled and performed. As a clinician, all I look at is the outcome, really. And one would always go with the honesty. If it's clinical research, I think these are ethically conducted trials, and one would hope that the outcomes are actually representative of the actual data that was obtained and analyzed.
Of course.
The important bits about limitations, as you said, is of course, yes, there is no neutral trial. This is the first trial with this medication. So I expected that pharma will have the biggest role. And hopefully now that we have the medication for us, we'll have neutral non-pharma trials in future and prospective studies we can do with our own university sort of clinics, which will hopefully then actually give us the real life data and compare it with what the pharma trials showed.
I agree. I think there's definitely. I think it's nice to see that innovation is always driven by pharma, but I think there need to be some more publicly funded research
Yes,
into this treatment.
yes, definitely, definitely. Just about quick word about what you pointed out about limitation is that, of course, the other bit is it's a short trial, so it's 1 year. We don't have information beyond 1 year, so of course it's a first trial with a new medication. One doesn't expect it to go on and on. Second one was that no breast cancer women as such specifically targeted, because we're expecting this medication will mainly be useful for women who will use non-hormonal treatments as a preference, and they may not want to use HRT. And the cancer group is one that's really the one that's most important from that regard, which wasn't in this particular trial. But as you rightly pointed out, and I think the company is also interested in running a trial specifically for breast cancer survivors. Yeah. So it will be great to be sort of watching out for results of that trial and what happens there.
100%. I think both you and I will be very keen to recruit into such a trial in the future. So
fingers crossed till we get to have a role in that.
So I think as a sum up, this RCT is helpful in showing us that there is good efficacy for both doses of this new drug to reduce moderate to severe vasomotor symptoms. This impact seems to be rapidly emerging after 1 week of taking it and reaching full maximum efficacy of within 4 weeks and then maintained throughout 52 weeks. And there could be some improvement with sleep. However, more data is needed. What do you think is the next step in terms of before we adopt it in clinical practice? What further research data we need?
Well, I think the license has been granted as we speak through and discuss this trial. So, of course, we'll have the hands on the medication in the coming year, in the new year. Some of the concerns when this trial was being reported was about safety, whether fezolinetant will be a problem for liver function tests, for kidney function tests. But actually, the safety was quite good. The safety profile, as you pointed out, the tolerance and the impact on the liver was not significant. Only 6 patients out of 500 had any elevation of liver enzyme, and it was asymptomatic and it was transient. No increase in bilirubin, if I read the paper right, about the upper limit into 2. So overall, it just means that, yes, well-tolerated drug will reduce your hot flushes by 50%. Future research, a long-term study needed. So we'll have to keep looking at what the 4-year, 5-year, 10-year outcomes are, which will only come with time. We need a specific trial in maybe endometrial cancer, breast cancer patients. That will be interesting. Then, as you pointed out, trials that also address sleep, mood, libido, energy in more details, other menopausal symptoms in addition to the hot flushes. And of course, bigger trial, it's just about 500 patients to begin with, but as we get more information, it'll be thousands and thousands of women. And in real life, maybe the drug may perform even better, or the drug may not live up to its expectation. One has to be open-minded and see what the real life effect will bring.
I agree fully. And actually, I think the Skylight 4 just been published, which is sort of the 52 week follow-up longitudinal of these women, which is, again, as you mentioned, showing very reassuring outcomes in terms of safety. And I actually came across a network meta-analysis that the company also sponsored, where they're trying to compare Fezolinetant to even HRT in terms of management of hot flushes. And again, I was a bit skeptical because there's not enough power in that network meta-analysis they're claiming is more effective than HRT, which or at least equal. I think we definitely need more data. And
yes, we certainly need more evidence there. But it's a good start. It's a positive scientific advance. And I think we should sort of keep our minds open, welcome the drug, see how it works for our patients. It will not be for everyone.
yeah,
Any medication has its pros and cons, and so will the Fezolinetant. So if you can find out the selected group of patients where it really does the job without any major side effects or problems, then we'll have a very good additional option, especially for women who can't take HRT.
completely agree. I think it's a nice addition to the repertoire of medication available for women with menopause. It's definitely not a front leader for now, but something to watch the space for. I guess this is our take-home message: is that I think exciting new drug coming to the clinical arena in terms of managing of menopause, and we will hopefully be sharing new insights about this on our symposium ongoingly.
Yes, and hopefully we'll do another one in 6 months or 1 year and update you with more trials as well
More
as what
information.
our experience in clinics has been. And we'll be happy to hear from you if you can come back to us whenever you've been able to use the drug or any other comments you have about the trials. You're more than welcome to contact us through the website or email or any other format to give us more updates on this. Thank you.
100%. Thank you all for joining today, and you can leave comments at the bottom or send us an email via the website, and we'll always come back to you. Thank you very much, Vikram, for today.
Thank you, Basil. Thank you so much.